Hello and welcome everybody. Am I audible and visible? A quick nod from your end and we shall be good to go for today's session. Is it audible and visible, guys? Just let me know in the comment section. I am still awaiting your confirmation. If it is there, I can see there is a bit of lag, and yes, it is live now, right? Is the AV clear, guys? I am still awaiting. All right. Let me just get back to this. 1 minute, guys. All right. Welcome, guys. Just give me a second. Yep. Is it okay now, guys? Let me know. Just refresh it. Just refresh it. All right. All right. As I can see that my image is a bit blur. All right. Sorry for that little technical difficulties. I hope now it is better. Yes, Renu. Now I'm looking better and not like a ghost, but like your host, isn't it? All right. So on that wonderful note, guys, let us begin with our today's session. Sorry about that little technical glitch which happens at times, but it is okay. Hi, Dr. Saad. Hi, Dr. Mohammed, Anuba, Adik, everybody. All right. Thank you all for joining in for today's session. So today we are going to be discussing IPL T20 in anesthesia, right? So it will be the INI-CET Premier League that we are having, and some of the important topics when it comes to anesthesia, we are going to be discussing that, right? So everybody is up and geared up for that. So be sure that you are there, and we are going to be discussing so many topics today that you will be overwhelmed at times, and you will be overjoyed also that you are able to solve so many questions, right? Oh, thank you, Saad. That is really, really wonderful on your part. I really appreciate that and your gesture on this wonderful platform. Don't worry. In next 1 hour, you will even feel more better, right? So everybody is up and geared up for today's session. A quick nod in the comment section if everything is clear now, AV quality, everything, so that we will be good to go. Wow, Dr. Saad, congratulations. That is really good. 4800 rank. Wonderful. So I am your host, your host, your mentor, your educator, your friend for the subject of anesthesia on this wonderful, wonderful platform of Unacademy. And I have been teaching now since more than like 6.5 years now. And I am with Unacademy since its inception, like 2019 onwards, right? So guys, there are a few courses that I want you to tell who all want to like join up. So you can use this 20% off which was there previously, but now it's gone. Now 10% off is there, and I believe that you can use this NEET PG and next course, which is like both recorded and live, which will be helpful for you for your preparations, right? So this is how the timetable for our IPL INI-CET looks like, right? IPL, that is INI-CET Premier League, and we are here right now solving anesthesia questions, which we will be very, very helpful for our upcoming INI-CET exams, right? There are still a couple of more sessions left. I hope you will be able to see all the sessions which we have concluded so far, so that it will help you with your preparations. All right. So these are some of the batches. That is Patho Micro Punch batch, which is there on your Unacademy store. Plus last mile FMG preparations. I don't know why the FMG date is not yet out. Hopefully this will be out in this coming week. That is what we are expecting. Let us see. For this 3 months course which is there for your last mile preparation, you can avail that for a very hefty discounted price which is mentioned here. Alright. And NEET PG Vitals, as you can see here guys, this is a very important thing that Unacademy has launched. Along with the live that we are taking right now, the classes, there are physical notes which will be available free for you, right? Who all subscribe for these Vitals, right? Also you will have this bundled approaches of plans, like with 6 there is 1 month extension, 9 there is 2 months, with 12 there is 3 months, and this is a limited period offer. And please, I will tell you who all are thinking that whether we should take up or not take up Unacademy. These are some of the last offers that are going on. After this there will not be any offers. That is what I can tell you. Alright, so shall we begin with the first MCQ of the day, guys? Alright Renu, I believe everything is good now. Full course anesthesia is available on Unacademy. Yes sir, it is available. Yes. Alright, so first thing, I want you all to look at this topics, right? It is IPL T20 20 most important topics that we know of, right? So if you see, in the last 5 years I have taken into account peri-op monitoring, right? In that, if you see capnography, one of the most important peri-op monitoring, right? Along with that, SpO2 is also nowadays again picking up after the COVID scenario particularly. Then your bispectral index monitoring and neuromuscular monitoring, right? So this perioperative monitoring will include all these important topics which we'll be discussing today. After that, if you see, there are this oxygen delivery system, O2 delivery systems, right? Particularly if you see again after COVID, all the oxygen delivery devices, all the oxygen delivery systems are being asked time and again, right? In that also, if you see different, sometimes they'll post a picture once, like it happens like in the same year, in the 2 different exams, like in November and in May, INI-CET exam, same image was there, right? And so it keeps on repeating. So you need to understand what are the important topics which are going around in last 5 years, right? Next comes your malignant hypothermia. This is nothing but this is your complications in anesthesia, right? So this complications in anesthesia, out of that, malignant hypothermia is one of the most important ones. Then comes your airway management. Particularly in airway management, if you take up last 1 year question paper, you will be able to see that airway maneuvers have been asked, right? Airway maneuvers have been asked particularly, like those head tilt, jaw thrust, chin lift maneuvers. So airway management is a very important topics. In that also, if you know, if you take into account, this Malampatti grading is one of the favorite questions of examiners. Along with that, application in form of Cormack-Lehane classification can also be done, right? Screen is half cut. All right, koi baat nahi. I'll be able to let you know as and when anything is there with regards to this. All right, let me just see if I can clarify this. I believe now it should be better. Alright, so next comes your lumbar puncture, right? Next comes your lumbar puncture. So in lumbar puncture, if you see, we will take it into account from the point of view of our regional anesthesia, right? From the point of view of our regional anesthesia. Then comes your local anesthetics, all the drugs which will include local anesthetics, muscle relaxant, inhalational and IV, right? All the 4 drugs that we are taking about into account are equally important, right? Of those, if you ask me any one particular to be picked, I'll pick up local anesthetic, right? It is very frequently asked question, not just in INI-CET but in NEET PG and FMGE as well, right? And last one that comes is your CPR. Why I've kept it at the last? Because it is one of the most important ones, right? All right. Okay, now I believe everything is okay, everything looks good on your screen and my screen as well. Now let us begin with the first question of the day, and every question will be single best answer type and you have to answer it in the comment section, right? First question of the day, which is there on your screen, right? Which layer is not pierced during the following procedure? Ligamentum flavum, arachnoid matter, supraspinous ligament, or skin, right? Which layer is not pierced during the following procedure? Ligamentum flavum, arachnoid matter, supraspinous ligament, or skin, right? So first you have to know what exactly is the procedure that is being performed here, right? After that you should be able to tell me the procedure which is being performed here, yes, which layer is not pierced in that, right? So looking at the particular image, are you able to point out which layer is not pierced here? Yes, I can see a couple of you giving answers at option B, couple of you giving answers as option C. Yes, Renu, Jyoti, S, Dr. Saad, I'm able to see in the chat section. Come on, keep on trying. See, if you perform mistakes here, it's fine, right? You should not be performing the same mistakes in the exam. That will be a hazardous for us, right? I'll take one more question on similar lines. Now tell me, this needle is used for, right? This needle is used for, whether this is used for spinal, whether this is used for epidural, whether this is used for brachial plexus block or intercostal nerve blocks, yes? This needle which is there is used for, yes? What is the name of this needle? First, then this needle is used for, right? This is Tuhi's needle, right? Tuhi's needle that we all call it and that we all know of, right? So this is Tuhi's needle, also called as epidural needle, right? Everybody? Wonderful guys. Yes, Saad, Jyoti, Renu, great attempt. Everybody please answer in the comment section. So this is the needle which is used for your epidural block or epidural anesthesia, right? What does the name epidural comes when we talk about epidural, right? When we talk about epidural comes in your mind, right? How to differentiate between epidural and spinal needle? We'll come to that as well, Dr. S. Yes. So first let us talk about the structures pierced, right? Starting right from your skin, subcutaneous tissue, then comes your ligament, right? Supraspinous ligament, interspinous ligament, then comes your ligamentum flavum, right? Then comes your dura mater, then comes your dura mater. After dura mater comes your DAP, remember, or PED, inside out, right? Dura mater, arachnoid mater, pia mater, and then is your spinal cord, right? So this is how your surfaces from skin to the subspinal cord looks like, right? Everybody? Yes. Where is epidural? Epidural, as the name itself says, it is epi means above what? Dura mater, right? So this is your epidural space. So which structure is not pierced? Arachnoid membrane is not pierced, right? What is arachnoid membrane when it is pierced? When we give subarachnoid block, that is known as your spinal anesthesia, right? That is known as your spinal anesthesia. Clear? So correct answer for this question, which layer is not pierced during the following procedure, is arachnoid matter, right? So which is pierced? Ligamentum flavum, is it pierced? Yes. After it is pierced, what do we get? We get loss of resistance, right? We get loss of resistance. Why? Because ligamentum flavum is the toughest of all the ligament. Clear, everybody? Yes. So correct answer for this question is option B. Again, correct answer for this question is option B. This needle is used for, right? Remember, how do you differentiate between a spinal needle and an epidural needle? First, you will have this markings. Are you all able to see and appreciate these markings? Yes, these are your at every centimeter, so that you know at what length are we entering the epidural space and we have to insert the catheter, right? So this one markings you will be able to see. Second is this hub needle that you are able to hold it, right? Properly when you are able to hold it, right? So how does a spinal needle looks like? It looks something like this. Yes. Are you able to see markings here? No. Are you able to see that hub or the needle that you are able to place and hold it? No, right? So these are the two differences that you should understand between spinal and epidural. Clear? Everybody? Yes, Dr. S. Now is it better? Are you able to differentiate between the two needles? Yes, no marking and no hub. Next question on your screen. The following capnograph suggest. The following capnograph suggest rebreathing, spontaneous efforts, pulmonary embolism, or malignant hyperthermia. Following capnograph suggest. Write down the answers in the comment section. Is the speed okay? Everybody? Yes. So look at this particular thing in the capnograph, right? What is happening here, right? In the phase 3 of the capnograph, this is phase 1, 2, 3. In the phase 3 of the capnograph, what is happening? There is a notch which is coming in, right? There is a notch which is coming in the phase 3 of the capnograph like this, right? So this notch is nothing but it is known as your curary cleft, right? This is known as your curary cleft. That is, there is a cleft, that is, there is an indrawing there. Exactly correct, Renu. Yes. So this actually suggests what? All of you have given correct answer. This actually suggests your patient is trying to breathe spontaneous. That means patient is coming out of your muscle relaxant. Clear? So this notch suggests that the patient is coming out of your muscle relaxant. That is, the patient is trying to take little spontaneous breath. Particularly the diaphragm movements which happen here, you will start to get these small clefts, right? These are nothing but whenever the graph goes down, this is the inspiratory effort, right? Whenever the graph goes down, this is the inspiratory effort, and whenever the graph goes up, it is the expiration which is happening, right? So this little inspiratory effort, that is known as your curary cleft. Now why do we call it curary? Because curary was the first muscle relaxant which was discovered or which was used, so it is known as curary cleft, right? That means the patient is coming out of muscle relaxant. All right. So S was asking, by sir, markings का significant क्या है? What is the significance of these markings, right? Suppose if I encounter the epidural space at 1, 2, 3 and 4 centimeter, right? So how much am I supposed to insert the catheter inside that space? That is what this marking will tell me, right? So these markings are very important in terms of correct placement of your epidural catheter, which will help us in intra-op as well as in post-op anesthesia and analgesia, both the places, right? Alright, next question on your screen, guys. Identify the position. Identify the position. Option A, Trendelenburg. Option B, reverse Trendelenburg. Option C, lithotomy. Option D, lateral decubitus. Or option E, that is jackknife positioning. Right? Identify the position which is there on your screen right now. Yes, options and answers here. Wonderful. Trendelenburg, reverse Trendelenburg. Trendelenburg, reverse Trendelenburg. These are generally the confusing options in our lifetimes, right? In the exam, what was asked? It was asked Trendelenburg, and I have just reversed it here, right? So what are the different positions? You should know this chart, right? So first is your supine position. That means you're lying down flat in the bed with your on your back, right? That is your supine position like this, right? Next is your prone position. What is there in prone position? You're lying down on your tummy, right? So that is your prone position. Then comes your Trendelenburg. So this is your Trendelenburg position. Trendelenburg. In this, the patient's head is down. Trendelenburg, right? Whenever the patient's head is up, it is reverse Trendelenburg. It is reverse Trendelenburg. Clear? Yes. So another position which I want all of you to know is your lithotomy position as well as the lateral position. These are some of the important positions that you should know. Fowler's position or beach chair position, that is usually being done in your posterior fossa cranial surgery. Do we practice it very frequently? Not very frequently, because of the complication that we all know as venous air embolism which happens there, right? But nowadays again it is coming back into our practice. Why? because we have got better modes to tackle that and also diagnose venous air embolism, right? So what was the question here? The question was head up position, which is there, right? So it is a reverse Trendelenburg. All right. Yes, Shahu, exactly correct. Everybody, are you now clear between Trendelenburg and reverse Trendelenburg, these two positions, right? So positioning in anesthesia, again an important topic. Guys, look at the kind of questions that we are discussing. I have taken in the last 5 years all the important topics and all the frequently asked questions we are clubbing up in this particular sessions, right? So this is going to be a very, 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 very high yield and important session. Next question. All are the benefits of supraglottic airway device over endotracheal tube except it requires less time for insertion, less hemodynamic changes are seen with this, it prevents aspiration, or it is less invasive. What is the correct answer? What is the correct answer here? Wonderful. Yes, C. Shahu. Yes, Saad, Renu, Ashi, staff, Aureus, Jyoti. Everybody of you have given correct answer. Yes, Varshit. Excellent. Everybody of you have given correct answer. That means we all know what are the benefits of supraglottic airway devices, right? Supraglottic airway devices. Nowadays, this supraglottic airway devices includes your airways, right? It also includes your LMAs, right? Laryngeal mask airway. Everything is clubbed into this supraglottic airway devices, right? So how does it look like? This is your supraglottic airway device. If I want to tell you in a broader aspect of term, but actually what it is, a type of supraglottic airway device. What is the name? It is LMA, laryngeal mask airway. As opposed to that, what is this? This is the endotracheal tube that you are able to see, right? So are you able to see the differences between the two, guys? Yes, both images are very important. And now recently even they have started to ask about tracheostomy, right? I have not taken the image of tracheostomy here. We will take it up in upcoming sessions, but tracheostomy was also asked in the recently concluded NEET PG, right? So you should know all the images, all the devices that we are going to be taking from the airway perspective, right? So airway management, that we have told, it is very important topic. So this is one of the important parts, right? So what do you know or mean by the term supraglottic airway device? That means it lies above the glottic opening, right? It lies above the glottic opening. That means it does not cross your vocal cords and goes into trachea. Clear? So what will happen if we are not able to go or cross the glottic opening and go into trachea? You won't require laryngoscopy, one. So if you don't require laryngoscopy, what will happen? Because of laryngoscopy, the hemodynamic response which is there will not happen. So one, it is easy to insert. Why? No laryngoscopy training is needed. Two, it will not cause any hemodynamic changes. Three, since it is easy to insert, it can be done by anybody and as well as in emergency situations, right? So which is the correct answer here? It requires less time for insertion. Yes. It is less hemodynamic. Yes. It is less invasive. Yes, because it is not going crossing the trachea. So what is left out? Does it prevent aspiration, right? It is asking about exception. Girlfriend googly question, right? All of you have got correct answer. So what prevents aspiration? This prevents aspiration. The cuff in the endotracheal tube prevents aspiration. Where it goes inside the trachea and you inflate the cuff, right? But here in LMA, do you have such kind of cuff? We have got this cuff, but it does not go inside the trachea. It just stays above the glottic opening and this tip lies over your esophagus, right? The entry point of your esophagus. Does it prevent aspiration? No, it does not prevent aspiration. Clear? Next question on similar lines on the same image. Following is used in CPR, difficult airway, cervical spine fractures, or all of the above. Think and then answer, right? So Dr. Saad is saying, sir, the image this time for NEET PG was confusing. Yes, Saad, this time they had asked about tracheostomy, as I have already mentioned, and I have not taken that image here. We'll come to that when we discuss recall questions, right? Or PYQs in the coming sessions. Yes, Saad, Dr. S, Shahu, Priya, Kapil Pathak, Ashi. Yes, So what are the answers? Difficult airway, CPR, cervical spine fracture. Yes, look at it logically and then answer, right? So what did we say? This is used in emergency scenarios, right? So is CPR an emergency scenario? Yes, it is an emergency scenario, right? What happens in difficult airway? You are not able to give the position. You are not able to give the position properly, or in difficult airway you will see that Malampatti grade is higher side, Cormac-Leone is again on the higher side, or you are not able to ventilate or intubate the patient, right? All these are accounted in your difficult airways, right? Cannot intubate, cannot ventilate everywhere. So if you go by the difficult airway algorithm, after laryngoscopy, if you are not able to perform or insert the endotracheal tube, next step is to insert element. So is it used in difficult airway? Absolutely yes, it is there in this algorithm. Cervical spine fracture, is it a difficult airway, guys? Yes, it is a difficult airway. Why? No sniffing position can be given, right? No movement at the spine should be done. So emergency scenarios, it is used. Difficult airway, it is used. Cervical spine fracture, again a difficult airway, it is used. So all of the above is the answer. Clear, everybody? Samjha? Understood? Next question. Identify the equipment. NIV, high flow nasal cannula, or oxygen concentrator, right? What is this image telling us about, right? I'll just move out of the screen so that you are able to look at the image properly. Yes. Renu, S, Saad, Priya, Pooja, Varshit, Docpedia, Ashi, Rinku, Kapil, everybody is giving correct answers. Very good, guys. This is nothing but this is your high flow nasal cannula. A couple of questions more on your oxygen delivery devices, right? This belongs to this topic, that is oxygen delivery devices, right? A couple of more questions and then we'll discuss all the things together, right? Next question. Identify this device, right? Is it option A, nebulizer, option B, face mask, option C, high flow nasal cannula, or option D, that is Venturi mask, right? Identify the device which is shown in your figure again. Very nice. Yes, Priya, S, Renu, Shahu, wonderful. Saad, Docpedia, Pooja, Varshit, Ashi, everybody is giving correct answers. Wonderful, guys. Glad to see that so many of you are giving correct answers for this particular question. So first one was what? It was high flow nasal cannula, right? Which is the second image that is being shown. This is the Venturi mask or Venturi device, right? Based upon your Venturi principle, right? So if you look at this, it is color coded, right? It is color coded. All right. Some more questions and we'll discuss again more in detail. Maximum FiO2 delivery is by Hudson mask, NRBM, nasal cannula, or Venturi mask. Maximum FiO2 delivery is by. What should be the answers here? Hudson mask, NRBM, nasal cannula, or Venturi mask, right? So what all we have seen? We have seen high flow nasal cannula, right? We have seen Venturi, right? So what are the two different things here? One is nasal cannula, the other one is NRBM, right? I can see most of you are almost giving correct answers. That is NRBM का full form क्या है? It is non-rebreathing face mask or non-rebreathing bag mask, right? NRBM. So let us have a look at the oxygen delivery devices that we all know of, guys. First, tell me in the comment section, what is the FiO2 that we are breathing at room air? Yes, how much is the oxygen that we are breathing in room air, right? So it is around 20%, 21%, right? So in room air, we are breathing oxygen percentage or FiO2 is around 21%. I'll write here, right? So whenever there is a situation like COVID, or whenever there is a situation where ARDS comes up, right? So how do we increase the oxygenation? How do we increase the SpO2, or for that matter avoiding hypoxia in a patient? By increasing the FiO2, right? First thing that we do is we increase the FiO2. Then we go with PEEP and other maneuvers that we know of, right? But generally, when the patient is breathing spontaneous, first thing that we can do is like increase the fraction of inspired oxygen. From 21% you can go up to 100%. 100% के ऊपर nothing, right? All oxygen that you are giving is, all air that you are giving is containing oxygen. That is the maximum that we can go, right? Yes, Shahu, Renu. So what are the delivery devices that can supply oxygen to the patient? That is known as your oxygen delivery devices. So far, is it clear, the basics? Yes. So what are the different oxygen delivery devices that we know of? First is your nasal cannula, right? Basic, your nasal prongs connected to your oxygen cylinder with a tubing that we all know of. We have seen it n number of times in the movies. I don't know if you have seen that movie. What is its name? Fault in Our Stars, right? In that, whatever the name is of that actress, she is always carrying this nasal cannula attached, right? So that is what is nasal cannula, which is there, right? And it is delivering oxygen to around 25 to 40% at the flow rates 1 to 6 liters, right? Whereas this is how your face mask look like, and it is giving FiO2 of around 40 to 60%, right? Then face tent, usually used in pediatric population because they will not allow you to keep that mask, right? So they will not allow you to keep that mask, so this tent is kept. Again, FiO2 is in the range 40%, right? Then comes your NRBM, which is here, right? If you see this NRBM, yes, there is a reservoir bag which is attached to the face mask, right? This reservoir bag or bag mask that we call it, it will help you with this non-rebreathing valve. The expired air is given out and that reservoir bag is now containing all oxygen. So you can give up to 90 to 95% of oxygen with NRBM. Remember that, right? This is your high flow nasal cannula. The remaining part we'll discuss now, whatever is there below that. High flow nasal cannula, you can give up to 100%. And look at the flow rates. It is around 60 to 70 liters per minute, right? 60 to 70 liters per minute. Alright. So here it is. Just look at this. This is your high flow nasal cannula. This is your flow meter. From here the oxygen will go. This is your humidifier. Why do we need humidifier? Because oxygen is a dry gas, right? It will all cause dryness, so we require humidified gases to be given. And here is your nasal cannula. What is the flow rate? 60 to 70 liters per minute. And what is the FiO2 to be delivered? Around 100% is the FiO2 which can be delivered, right? Next came your Venturi. These are fixed performance, right? Fixed performance mask or devices. That means with individual color, right, different color coding, you will be able to deliver different FiO2s, right? If you look at this image, just look here, Venturi mask, it is a precisely controlled FiO2. If you look at all the other oxygen delivery system, what it is telling? It is telling around 25 to 40, 40 to 60, 80 to 95, right? No, none of the oxygen delivery system is telling you that precisely 40%, 50%, yeah, 60% FiO2 delivery will be given, except for Venturi, right? So Venturi is used in particular scenarios where we want to deliver specific FiO2 to the patient, right? So therefore it is known as fixed performance device, right? So all of you have given correct answers of question 1 and 2. Second, maximum FiO2 delivery is by, the correct answer here is NRBM. If I would have given the option as high flow nasal cannula here, your correct answer should be HFNC, right? Around 100% is given by this. Clear, everybody? High flow nasal cannula, Venturi mask, and even FiO2 delivery with other devices. Is it clear? Yes, sir. It is option E, that is high flow nasal cannula. Alright. Next question. Size of this IV cannula. Size of this IV cannula. The correct answers, yes, most of you are telling that it is option B. Everybody of you are correct here, right? Now if I change the color, right, instead of this, if I make it yellow color, yes, what is the size of this yellow colored IV cannula? Yes, what is the size of this yellow colored IV cannula? What is the size of this yellow colored IV cannula? 22, 24, 22, 24, right? If this is 22 or 24, then what is this blue color of IV cannula? What is the size of this blue colored IV cannula? Yes, Sad, S, Rinku, Varshit, Kapil, Renu, Priya, Shahu. After this, I'll ask you size of violet or purple color of IV cannula. Write down in the comment section. Keep on writing so that your brain is stimulated. Right? 22. Everybody of you is correct. Yes, Docpedia, Priya, Renu. Yes. Whenever we go out of our comfort zone, are you able to see that we are not able to answer them correctly? Right? When the options are gone, suddenly I see the number of options or number of answers coming down. Right? Next, size of this IV cannula. Consider this as pink. Right? This is pink color. Not red, this is pink color, right? What is the size of this pink colored IV cannula? All right. So how do we remember the different IV cannulas and different colors, right? With the help of this wonderful picture that we all know of, right? So what is present beneath the earth? It is lava. Lava is what? It is orange in color. Soil, below the soil there is lava, which is orange in color, right? Then comes your soil or mud that we call it. Consider it as gray colored, right? Next comes your beautiful grass or trees that we are able to see surrounding everywhere, the lush green forest above the soil, right? Then there is a beautiful rose plant which is giving pink colored rose on that particular flower which is there, right? Plant. Then comes the blue sky above you, and then comes the sun, right? Just imagine the nature and you will be able to answer all the questions, right? So first is what? Orange colored lava, right? So 14. Go on increasing 2 every time and you should be able to answer all the questions, right? Then comes your soil, which is grey in color, 16. Then comes grass, which is green in color, it is 18. Then comes the beautiful pink flower on top of that, 20. What is the sun or what is the sky color? Blue. Blue is 22. Then again increase it by 2. That is your sun, that is 24. And if you go beyond the sun, what do you see? You see the galaxy, the twinkling stars. Consider it as purple, which is 26 gauge. Right? Nice trick to remember. Yes, just remember this once and you will be able to answer this question forever in your lifetime. Right? Lava, soil, green grass, pink flower, to the beautiful blue sky and the sun. Alright? Now, an extension of it is usually asked, which is the flow rate, right? That is flow rate per minute, right? Start from below. If you start from 26 gauge, it is around 10 to 13 liters per ml per minute, right? It is ml per minute. If you can see, the flow rate is in ml per minute, right? Just go on increasing from there on right up to 14 gauge. 14 gauge is the maximum, which is around 250 liters or 250 ml per minute. Why am I telling liters all the time, right? It is 250 ml per minute, right? So then comes your 18 gauge. If you go there, yes, just divide it by 2. 18 divided by 2 is 9. So 90 is your 18 gauge, right? Dr. Saad, you have already told. Wonderful. 16 gauge, 16G, it is around 160 to 180, right? 160 to 180 ml per minute, right? So if you know, you will be able to correlate it with the gauge, the flow rates as well, right? Smallest one is 26. 26 ka half is 13. 18 divided by 2 is 9. So again it is there in that same range. Maximum is 250, lowest is 10 to 13, right? On top of that, you will be able to build up all the things. Clear, everybody? Yes. So correct answers for this question, I hope all of you have given. The green one was 18. Then all the things we kept on building up on top of that. Clear? So cannula, color coding and flow rates, both the things are important. Next one on your screen. Blue pipeline in OT is for which anesthetic gas? Air, oxygen, nitrous oxide or vacuum? Blue pipeline in OT is for which gas? See, it is asking about pipeline, right? It is asking about pipeline. So be sure when you are answering. Yes, Renu, Saad, C, S, Pooja, Varshit, Priya, Docpedia, Shahu, every one of you are correct, not to worry. So, a patient of COVID 19 requires oxygen, right? Now it is asking you about cylinder. Let me know about what you know about cylinder, right? Oxygen cylinder, right? Is it brown color, blue body with white shoulder, black body with white shoulder, or blue colored, right? Unacademy t-shirt, है ना? Remember that? Yes, so it is black body with white shoulders like your oxygen. So correct answer here is your option C. Everybody of you have given correct, right? So coming to the pipeline, see guys how the trends are changing, right? Till now, cylinder used to be the favorite question of examiners. Now they have started asking about the pipelines. So what was asked now? Blue colored pipeline, right? So this is N2O, all of you have given correct. What about yellow colored? Write down in the comment section. Yellow color pipeline in the OT contains or carries what it is used for. The answer is vacuum or suction, right? It is carrying or it is having vacuum or suction. Yes, exactly correct. What about white color? What about white color? Most of us are confused now between white and between black pipeline, right? What about white? White is your night. So white night is your oxygen, right? And the black is air, right? Black one is your air, right? White is your white night, that is your oxygen. So blue color pipeline in the OT is nitrous oxide. All the different pipelines now we know of, right? This is how you should study, right? You should not just go with one question which is asked, that is how, but you should be able to completely complete that topic, right? The applied anatomy, as we call it, or the various appliances, various applications of that particular topic should be completed in detail. All right. Next question. Airway resistance to the flow of gases through the endotracheal tube is due to the diameter, that means the internal diameter it is asking, right? Or radius I can write here. Curvature, length, or material of the endotracheal tube that is used, right? So airway resistance to the flow of gases through the endotracheal tube is due to, right? Just look at this pipe. This is a large pipe and this is a small pipe, right? Through which you would say that the flow of water is carrying or having more resistance, right? All of us have watered the plants, right? Sometimes in a lifetime, right? In the garden or somewhere, right? So what happens if you want to water a plant which is far off? What do? We press our thumb on that, right? So what happens? The flow increases. Why? Because the resistance and velocity. Here comes your Wick's principle, right? So once you press it, what happens? The pressure increases, so the resistance increases basically. So velocity also increases and goes far. Correct? So the resistance is more in the smaller pipes. Same thing applies to the gases as well. The more it will go through the narrowed pipes, the more will be the pressure, the more will be the resistance. So while putting the endotracheal tube, always use an optimum size. The smaller you will use, the more will be the airway pressure, the more will be the resistance to the flow of gases. Clear? And if you want to see, the resistance is inversely proportional to the power of 4 of the radius, right? Power of 4. That means if you increase it by 2, the resistance increases 16 times, right? Or if you decrease it by 2, the resistance increases 16 times. So that is how critical using the correct size of the tube matters here. Correct answer is diameter. Alright. Turbulent flow, linear flow, that is also there into account, but that will be too much of a detail, right, Dr. Sir? Next question. Which of the following causes methemoglobinemia? Right? Which of the following causes methemoglobinemia? The options are lignocaine, benzocaine, chloroprocaine, or dibucaine. Which of the following causes methemoglobinemia? Local anesthetic, right? What was the mnemonic for this? Paneer butter masala, right? Paneer butter masala. This is the mnemonic, right? So prilocaine, B stands for benzocaine, M stands for methemoglobinemia, right? So prilocaine and benzocaine, exactly correct, Renu. So it is paneer butter masala. Prilocaine and benzocaine causes methemoglobinemia. Clear, guys? So correct answer here is option B, right? Factual question, nothing much in it. Option B is the correct answer, right? Not chloroprocaine, neither it is dibucaine. Next question on your screen. Yes, Dr. Saad, this is how you will remember it forever. An elderly female, hypertensive, unconscious. She gave a history of severe headache. There is no history of trauma. Respiratory rate right now is on the higher side, 18 per minute. Pulse is okay, 86 per minute, but BP is 250 by 120 millimeters of mercury, right? During rapid sequence induction, which of the following is contraindicated? Right? The options are propofol, ketamine, midazolam, and etomidate. During rapid sequence induction, which of the following is contraindicated? Option B, option A, option B, option A, right? See, first of all, you should understand that the patient gave history of headache, right? And right now she is unconscious, right? Along with that, the patient was hypertensive, and this indicates signs of increased ICP, right? That means there can be intracranial hemorrhage which would have occurred, right? So once there is an ICH or ICH, what will it lead to? It will lead to increase in ICP. So which of the following drugs will you avoid whenever there is increase in ICP, intracranial pressure, whenever it is high, right? So let us go to the CNS aspect of our IV induction agents. All these are what? These are IV induction agents, right? So propofol, does it cause increase in ICP or decrease in ICP, guys? Propofol causes decrease in ICP, right? Ketamine. Ketamine is the only drug which causes increase in ICP. Only drug means only IV induction agent, right? Midazolam may cause increase in ICP if you are not ventilating it properly, otherwise it has got no effect, right? Etomidate causes decrease in ICP. If I add one more, thiopentone also causes decrease in ICP. So which of the following agent is contraindicated? It is ketamine, right? So guys, just look at the question once again, right? It is asking about rapid sequence induction, right? It is asking about rapid sequence induction. So can I say midazolam is also one of the better answers here? Midazolam, is it rapid acting or slow acting? It is slow acting IV induction agent, right? Do you remember that? Midazolam is slow acting IV induction agent, right? But why did I still go with ketamine? Because the patient was already unconscious, right? The patient was already unconscious. So I will hardly require any IV sedative or hypnotic agents. Even if I give midaz and go ahead with muscle relaxant, I should be able to intubate the patient. Did you get it, guys? Yes? Did you understand this particular line? Patient is already unconscious, right? So therefore I preferred ketamine over midazolam because of its increase in ICP, which was making more sense. Wonderful. One more question on similar lines. Read the question, right? It is different here. An elderly female, again hypertensive, unconscious, severe headache, gave history, no history of trauma, respiratory rate, pulse, BP, all are same. During RSI, which of the following is preferred here, right? Atracurium, cis-atracurium, rocuronium or vecuronium, right? During RSI, which of the following is preferred here? Yes. RSI means what, guys? It is rapid sequence induction. I hope you know that, right? R stands for rapid, S is sequence, I stands for induction. It is rapid sequence induction. Wonderful, wonderful, wonderful. Most of you have given correct answers. So during rapid sequence induction, what do we want? We want the patient to be in muscle paralysis, and we want the action onset of that particular drug to happen very fast, so that we avoid, what do we avoid here? The regurgitation and aspiration, right? So what happens during RSI is usually done whenever the patient is full stomach, right? Whenever the patient is full stomach, right? And remember, all pregnancy and all head injury patients, right, unconscious, raised ICP, pregnant females, they are always considered full stomach, right? I am repeating it. Head injury patients, raised ICP patients, pregnant females, they are always considered full stomach. So always consider going ahead with rapid sequence induction in such patients. Clear? Right? So rapid sequence induction is done to avoid aspiration. What happens whenever the patient regurgitates or aspirates? Yes, it will lead to chemical pneumonia, right? Unnecessarily you will be having extra complication on top of that, whatever you are doing it for, right? So how do we go ahead with rapid sequence induction? During that, we do not perform positive pressure ventilation and we perform Silix maneuver, right? Rapid sequence induction, we perform Silix maneuver, right? So during RSI, which of the following is preferred here? Whichever will have the shortest onset of action. Shortest onset of action. Right? Okay? So which of the following has got shortest onset of action? It is rocuronium. It is around 90 seconds. The onset of action of rocuronium is around 90 seconds. Whereas atra, cisetra, vecuronium, all these have onset at around 180 seconds to even 6 minutes, right? 3 minutes to 6 minutes. 3 minutes is the ideal time, right? So considering this, rocuronium is the drug of choice. Always remember, it is the drug of choice for rapid sequence induction. All right. And also one more thing, what is the antagonist which is being asked nowadays, right? Antagonist to rocuronium. Yes, specific antagonist. Anybody in the comment section? I'll give you a chocolate. Antagonist for rocuronium. Nowadays it is available in India, right? Till now it was not available, but now it is available in India. Yes, yes, Dr. Priya, a chocolate for you. Wonderful. It is Sucamadex, right? Yes, Saad. Yes, Teja. It is Sucamadex. Exactly correct, Shamu, right? So did you understand the two questions, right? Similar questions, just the options we played ahead with in terms of induction and in terms of muscle relaxant, right? More questions coming up on muscle relaxant. The first one on your screen. Fastest acting. Succinylcholine, mivacurium, rocuronium or atracurium, right? फास्टेस्ट एक्टिंग सक्सिनलकोलिन, मिवाक्यूरियम, रॉक्यूरोनियम और एट्राक्यूरियम. सात के पहले के 2 सेशंस के चॉकलेट्स ड्यू है. ऑलराइट साथ, वन मोर. ऑप्शन सी, ऑप्शन बी, ऑप्शन ए. यस, everybody has read the question? Yes, I'll take one more question on this front, right? Now tell me, what should be your answer here, right? This is a different question compared to the previous question. Fastest acting muscle relaxant I am asking you, right? Succinylcholine, mivacurium, rocuronium, atracurium, same options. Now let me know in the comment section what are your answers here, right? Are you going to change your answer or are you going to stick to the same answer? Yes. Option A, option B, option C and option D. Succinylcholine, mivacurium, rocuronium, atracurium. All right, all right. So did you understand the difference? I'll again go back to the previous question here. Yeah. Fastest acting non-depolarizing muscle relaxant. Yes. Now tell me what should be your answers. Yes. Look at the change here. It is asking non-depolarizing muscle relaxant, NDMR, right? And what was the previous one or the last one that we concluded with? It was fastest acting muscle relaxant. So did you understand the difference between the two? Yes. Alright, still people are confused. I'll change the question and now you tell me in the options, right? Instead of fastest, I'll write here shortest acting non-depolarizing muscle relaxant, right? Shortest acting non-depolarizing muscle relaxant. So are you able to get the difference between shortest, fastest, longest? Yes. Are you able to gauge the difference? Yes. Fastest acting means onset, which is fast to bring about muscle relaxation. Right? Fastest acting muscle relaxant. That means onset of action. Right? So fastest acting muscle relaxant, that means onset is asking. Just now we have seen which one will prefer. These will prefer for rapid sequence induction. Right? So fastest acting non-depolarizing muscle relaxant, it is rocuronium. Why? Because onset is 90 seconds, and specifically it is asking about non-depolarizing, right? Whereas mivacurium and atracurium, the onset is 180 seconds, right? Onset is 180 seconds, right? Now coming to the second, shortest acting, right? Shortest acting, right? Shortest acting here is mivacurium. Why? The duration of action of mivacurium is less than 20 minutes. I'll write here, right? It is less than 20 minutes, around 10 to 15 minutes is the duration, 10 minutes around what you consider, but I'm writing here broadly less than 20 minutes. Whereas rocuronium and atracurium, it is intermediate, 20 to 40 minutes. Got it, guys? We are talking about non-depolarizing muscle relaxants here. Next question was fastest acting muscle relaxant. In general, it was asking about muscle relaxant here. It does not differentiate here between depolarizing or non-depolarizing. Here, what should be your answer? It should be succinylcholine. Why? Because the onset of succinylcholine is 30 to 60 seconds, right? Onset of succinylcholine is 30 to 60 seconds. So if you are asked for rapid sequence induction and if succinylcholine is there in the option, first answer has to be succinylcholine. Second best answer is rocuronium. Clear? So did you understand the differences? Fastest acting non-depolarizing muscle relaxant, fastest acting muscle relaxant, and shortest acting muscle relaxant, right? These little words is what the examiner will play you with, right? So if you are able to understand the nuances of the question, you should be able to answer them, right? But most of the time the examiner tries to play with the options. Same way is going to happen with the questions as well. Everything clear? Yes? Because we were confused between miva, we were confused between succinylcholine, we were confused between rocuronium. So non-depolarizing, depolarizing, right? Or muscle relaxant in general, right? So if I take up muscle relaxant, I can classify it as depolarizing muscle relaxant, which will include succinylcholine, and non-depolarizing muscle relaxant, which will include all of these, right? Apart from succinylcholine, all of these are included in that. Alright, moving on to the next question. Color of sevoflurane vaporizer. This is like an easy peasy question, right? There are 2-3 questions which are lined up with inhalational anesthetic. We'll just solve it in a jiffy. Yes. Very good, guys. Next one, color of halothane vaporizer, right? If you know this, next question should be an easy one for you. Color of halothane vaporizer, right? If you know this, next question should be easy one for you. Wonderful. Now tell me, this inhalational anesthetic agent causes what? Nephrotoxicity, hepatitis, cardiotoxicity, or bronchial asthma. This inhalational anesthetic agent causes what? Right? This we have discussed a couple of times. We already know, right? How do we actually find and classify and diagnose with the help of color coding the inhalational anesthetic with the vaporizer? Halo around the sun, right? What is the halo around the sun when the sun rises or when the sun sets? It is red in color, right? So halo around the sun, it is red in color. So red is halothane, right? Red color is halothane, right? Next, we all love to eat that sev bhujia, aloo bhujia, right? Bikaner bhujia, right? So sev, what is the color of sev? Sev is yellow in color. So sevoflurane. Sev is yellow in color, right? Sev bhujia. Remember that, right? What is the color of Indian cricket team's desi jersey? Desi jersey of Indian cricket team. Desflurane. Desi jersey of Indian cricket team is blue in color. So desflurane, right? And remember that Amir Khan was punched out in the eye in the movie Dil Chahta Hai, right? After that song Koi Kahe Kehta Rahe, hai na? In that party, when he proposes to Preeti Zinta, what is the color of his eye? His eye becomes purple or violet in color, right? So eye for eye. Whenever Akshay Khanna or what is his name? Saif Ali Khan also mentions why is the color of your eye so different, right? So eye for eye, right? Isoflurane is violet in color, purple in color. Isoflurane, right? Eye for eye. Clear, right? So red color of vaporizer, first it is halothane, that we all know now, right? Halothane cause halothane. H for halothane, H for heart, H for hepatitis. Remember, we all have seen this triple H, yes, WWE. H for halothane, H for heart, and H for hepatitis. Halothane causes hepatitis. Halothane is a direct myocardial depressant. It is a direct myocardial depressant, right? H for heart, H for halothane, H for hepatitis. Color of halothane vaporizer, red. All of you have given correct answers. Sevoflurane, save is yellow in color, so option is C. Clear? Yes, everybody? Yes, save, it is saving or savior in asthma. That also is there. But due to time constraint, we won't be able to take more questions. I hope you guys enjoyed. Guys, we have stick to the basic question. If you see all the topics that we have discussed in the beginning, we were sticking to those topics because these were the 5 years question which were asked, right? There are more questions which we will cover in the special class which will be coming up in this week, right? So don't forget to follow me on the Unacademy app so that you get notifications whenever we are coming up with our next sessions. And also this IPL T20 series, with the help of these particular topics which are most important ones. If you want, you can take a screenshot of it. This is what you have to complete. The topics I am talking about, right? Not just questions, the topics which we have to complete before going for the INI-CET examination, right? So I hope you guys enjoyed today's session. All right. Though it started with a bit of glitch, but I hope we are ending it with a bang, right? Our super over, the first 6 overs were not those good, but we ended up with a bang, right? Isn't it? There was a little glitch in the beginning, but I'm expecting that you guys have enjoyed the session so far. Thank you all for joining in. Thank you, Rinku. Thank you, Priya. Thank you, Saad. Yes, wonderful that you liked all of my sessions. It is really an appreciation which we really love from all of students, right? So let us conclude our match for the day, right? Any suggestions, anything that you have, any questions are more than welcome, and you will be able to connect with me on the community section of our particular platform of Unacademy. If you have downloaded the app, you can let me know any of your suggestions or queries in the comment section here. I do go through that, and any suggestions to improve ourselves is more than welcome. And don't forget to subscribe. All right. Thank you guys. Thank you so much, Jyoti. Thank you, Kardinga. Thank you, Renu. Thank you, Docpedia, for joining me. So did you choose anesthesia, Pooja? Yes, I did choose anesthesia, and anesthesia also chose me. It was a kind of a story that I can tell you, right? When I was in my MBBS days, I used to see an anesthetist in my area who used to we obviously have a shop there. So he used to come at a shop, he used to sit, he used to chat, and he used to get a call, and he used to have a Vespa scooter, right? He used to take his scooter and go on again, take a call, finish off that case and come back. And I used to imagine what a wonderful life he's having, right? So I also looked at him and I said, either way I have to come back to my hometown, so I'll also become an anesthetist, right? So that is how I was looking up to the branch that time. But it is not like that. It was kind of fairy tale that I looked it from the outside. It is completely different, you know. Yes, it was by choice that it started off because of that. But over a period of time, over the course of time, as and when I grow up, as and when the wisdom dawned upon me, I took it up a little differently now, right? So it was because of that practice freelancing that I used to look it up. But then I realized different things during anesthesia, which I'll discuss when we discuss about anesthesia as a career, isn't it? Alright, Pooja. Yes, Dr. Jyoti, I am a full-time consultant neuroanesthesiologist working at a corporate hospital, cum trust hospital in Surat. Yes. So I do work as a full-time neuroanesthesiologist, and my day usually starts at around 6:30 in the morning with the cases. All right. Uh, no, I did not like freelance as a career option for anesthesia. Therefore, I have preferred to go ahead with the fellowships, and that too in such fellowships where I'll be able to become and get attached to an institute of my choice. So, therefore, I do not like freelance per se. Right? Initially, it is good, but long term aspect, long term preview UCC, always be attached to an institute. All right, all right, all right. Thank you all guys for joining in. I hope you guys enjoyed. I'll give you more insights about anesthesia as a career, about anesthesia as a choice, about my life in general in our coming special classes. We'll discuss that as well. All right. Thank you all for joining in, guys. Bye bye. Take care. Stay blessed, stay disciplined, and stay motivated, guys. This is your host, your mentor, your educator, Dr. Hitesh, signing off for the day, guys. Bye bye.